invited them. Some of them are already part of our team, and we will continue to do so as the process continues and evolves. So please send us any recommendation that you think of for a speaker or panelist. Very good. So it's 5 minutes past 8. I think we'll start the process for today, and then people will gradually trickle in. I will start by having I will have the speaker introduce herself and her background and her topic that she would be reviewing today before she makes a 15 to 20-minute presentation. And then we will jump right into the questions after introducing the panelists afterwards. So Dr. Zeenat Safdar, please go ahead.
Assalamu alaikum. This is Zeenat Safdar. I am a pulmonary critical care trained physician in Houston Methodist Hospital, affiliated with Weill Cornell in Houston, Texas. I am an SMCN graduate from 1991, and my primary interest is pulmonary hypertension. And I'll be talking about update on COVID-19 and the research that's going on right now. Thank you.
Dr. Safdar, please go ahead and introduce your topic, and you can jump right in.
Okay, all right. So the topic is, I'm going to talk about COVID update. And what we know right now, there's been a lot of information and there's been a lot of misinformation about COVID-19, how we all know it came from Wuhan. We all know it's a small virus that becomes aerosolized indoor and stays aerosolized, which means कि वो हवा में रहता है. अगर आप अंदर हो, पेशेंट हो आपके पास, या अगर आप घर वाले हो या फ्रेंड्स में बैठे हो, तो it will stay indoors near you for up to 3 hours. So that is the reason why it is so infectious. It came about in Wuhan province in December of 2019 from a seafood market. And then it came to US in around January from a person who traveled from Wuhan. So initial thinking was that this is transmitted and its travel history is important. But since then we have learned that initially it may have been the travel, but now it is person-to-person transmission. And there's a theory that it actually came from animals, bats maybe. And the reason for that is because जब उन्होंने test किया bats को, they found the same corona genetic changes, and so therefore they identified that the human corona most likely came from the same bat. Although there's no direct, other than that, there's no other evidence. We know that it is aerosolized, which is very, very important, so that we know this particle can stay lingering, and it can be not just by cough and talking also, but it can stay in the environment for a prolonged period of time, which is very, very important. We know for about 24 hours, it can stay on the cardboard box, on a plastic, 2 to 3 days, and a stainless steel in up to 2 to 3 days. So it's very important to disinfect. It's very important to wash your hands. And it's very important to be careful where you are. It is shed in the stool and it is present in the whole blood, but up till now, we don't know, and we are not sure whether it is shed in urine. Data suggests that it's not. The way it is present is most likely in the upper airway, nasopharyngeal. Coronavirus leads to common cold, जो हम लोगों को सबको खांसी जुकाम होता है. That is what it is. It has been around for ages, but this, because of the mutation that happened in this virus, it has now become very infectious, meaning कि spread बहुत ज़्यादा हो रहा है, जिसकी वजह से this is the whole pandemic is what we are facing right now. The other point is that a lot of patients, 80% of the people who have this virus are asymptomatic, which means that they don't know they have it, they're healthy, they will never get sick, but 20% will really become symptomatic. And those are the people that we test, those are the people that we are treating. And all the treatment is mainly symptomatic. And there is some data coming out that I'm going to talk about a little later. So the question, a couple of times the question came कि कब तक shed होता है virus in the sputum and in the nasopharyngeal secretions. Data suggests that it can last up to 24 days. 24 दिन तक nasopharyngeal secretions में जो वायरस है वो शेड होगा. Right now, we know कि उनका incubation period can be anywhere from 2 to 7 days. Quarantine, जो patient जो positive हो जाते हैं, they're advised to stay indoors, away from everybody, away from their family, away from their everybody, use a separate bathroom, sleep in a separate room for 14 days. But we know that up to 24 days, it can shed. And it can affect, and one person can affect more than 10 people. That is the whole problem with this virus, that we as asymptomatic carriers can be carrying it to other people. Now, the case fatality rate is low for this virus, and that is a good thing. It's about 1 to 4% estimate, and in Italy and China, it's about 2.3%. Right now, in US, we are looking at about 3% case fatality rate. Now the question about reinfection, एक question पहले आया था कि do people get reinfected? There is data that shows that there are neutralizing antibodies which are generated by B cells in a convalescent patient, and that that gives immunity to that person. The question is that how long is that immunity going to last, and is it lifelong immunity or is it a short-term immunity? We don't know, and we don't know if that antibodies causes resistance to reinfection. But we know that it does in animals, but human data is still lacking. Vulnerable population is nursing home because that is a big outbreak in Seattle that happened in US. Homeless population, especially older people more than 65 who have comorbidities. There was one other thinking that it is in pet owners, and right now there is not such a strong evidence कि pet owners में ज़्यादा होता है, यानी कि जिनके पास animals होते हैं. But there was this आप लोगों ने देखा सुना होगा news कि there was one I think lion zoo animal जिसको positive हो गया था in corona in US. The high risk population is more than 65, as I said, immunocompromised, patients who have active malignancy, lung problem, chronic lung problems, chronic kidney problem, high blood pressure, coronary artery disease, diabetes. Those are the things that are going to cause it. The most common presenting symptom is fever, dry cough, sore throat, shortness of breath. There's a lot of fatigue and muscle ache. One of the patients said कि मुझे इतना body ache है कि I cannot lift my arm and my leg, and there is severe chest pressure. Headache is very common also, and loss of smell and loss of taste. And ज़रूरी नहीं कि दोनों हो. Some patients have loss of smell, other patients have loss of taste. And a lot of this virus ends up in the lung because the reason why it ends up in the lung and causes lung failure or acute lung injury and ARDS is because the coronavirus itself binds to ACE2 receptors. And this ACE2 receptor is highly expressed in the lungs. And it is present on alveolar type 2 macrophages that secrete surfactant. And surfactant is very important for our well-being and keeping the lung functioning. So when there is no surfactant, it leads to acute lung injury, and it lead to profound hypoxemia and respiratory failure. Now, in patients who have this, they will require oxygen. But if their requirement for oxygen becomes high, which means कि अगर आप देख रहे हैं कि एक patient room air पे थे 2 liters चाहिए, फिर 4, फिर 6, that's an indication that this patient will need intubation. उसके लिए it's better to get prepared that this patient will need within the next few hours intubation and have everything ready for the intubation with all the PPEs, the gown, the gloves, the goggles, the face shield. In non-invasive ventilation like CPAP and BiPAP is not recommended. But there are ways of intubating the patient and using the CPAP as a pressure ventilation. And that is also can be done with a CPAP or a BiPAP machine. And for that, you should talk to your anesthesiologist or people that manage the critical care physicians. Intubation should be rapid sequence intubation, which means कि आप everything is streamlined और आप जल्दी से intubate कर दें उसको. आप usually हम intubation के लिए पहले उनको oxygen देते हैं और bag करते हैं, वो avoid करें, बल्कि directly उनको जितनी जल्दी हो सके intubate कर दें. But make sure that you yourself are wearing a proper N95 or KN95 mask. Now, the respiratory failure happens very fast in these patients within 12 to 24 hours, and it can happen anytime during the illness. Usually जो अभी देखा गया है कि these patients, they do okay and they start to get better, and then suddenly after a couple of days they collapse, they decompensate. So it can happen anytime between day 8 to day 12 of illness. It's acute onset of worsening. They require ventilation. When they do, it should be low tidal volume, not more than 6 ml per kg. I think there is going to be a seminar and a workshop on ventilation separately, sponsored by APPNA MERIT. In US, we do prone positioning routinely, which means कि उनको उनके पेट पे लिटाएं during intubation with intubated patient, which is very difficult. It is time consuming, and it is also labor intensive, क्योंकि काफ़ी 3-4 लोग चाहिए होते हैं patient को flip करने के लिए, और flipping के लिए you have to flip them back also ताकि उनको ulcers ना develop हो जाए. So that is something that is routinely being done in our ICU. Steroids, there is no clinical evidence of benefit from steroids. Agar patient is on high dose pressors, epinephrine, norepinephrine, और आप समझते हैं कि इनको steroid adrenal insufficiency है, तो फिर you can give them steroids. Most of these patients do not wheeze. If they are wheezing, then you can give them steroids. But do not give them any nebulizer treatment, because वो nebulize करके वो virus भी nebulize हो जाएगा, और जितने लोग कमरे में होंगे, potentially it's a risk for them. There was one.
I apologize to interject. A couple of things. This is Junaid from the Neurointensive.
जी कहिए.
Junaid will keep all the questions and comments at the end. Dr. Zeenat Safdar is our speaker today. I'm sorry you didn't join early. I couldn't explain the format to you. Dr. Zeenat, please go ahead and finish your talk.
Okay, sorry. So the other thing is, in terms of medications, there are a couple of medications that we are using here, and there's many medicines in the pipeline. There are many medicines which are being used in as a research protocol, जो available हैं in different parts of the world. Hydroxychloroquine की जो dose है, जो use हो रही है अभी 400 milligram BID on the first day, followed by 200 Q12. And it's usually given for 5 days. There is a lot of data. There's some data coming out saying that it is helpful. There's some data coming out that it's not. There's also a combination study showing hydroxychloroquine with azithromycin, and that study was withdrawn recently because of a problem with methodology. Chloroquine itself can be given also, but hydroxychloroquine is thought to be superior. Of course, there are side effects associated with this, which are very significant with this medication, especially cardiomyopathy, retinopathy, the patient can go blind, bone marrow suppression, and most importantly, QT prolongation. EKG has to be done and monitored, especially if you're using a combination of hydroxychloroquine with azithromycin. Now, the other medicine that people are talking about is remdesivir. It inhibits viral polymerase, and it basically causes block in replication. It is in patients are given this as part of a clinical trial. Now, the other antiretroviral medications, lopinavir and ritonavir, is used in HIV. And it is being used as an antiviral medication in this pandemic. There's IL-6 agents which are used, but they are part of a study. They are not routinely used. They have to be enrolled in studies. Other question was about convalescent plasma, I think, and a lot of promise. Early data suggests that it could be, it's a very old therapy. We used to use it many, many years ago, decades ago, where patients who have recovered plasma, antibody-rich plasma is recovered from them, and approximately 200 to 400 ml is given. We do not know if that confers how long that immunity is going to last, but of course, those studies are also ongoing, and we are part of the clinical trials in which we are giving this as a compassionate use. The one thing about ACE inhibitors, there was ACE and ARBs, there was in humans, I mean, a lot of patients are on ACE and ARBs, and people were taking those patients, they were withdrawing those drugs, and there is actually data suggesting that there is no need to do that. I won't go into mechanism of that, but it's not recommended to withdraw or stop these medicines. The reason why people were doing it is because as the virus is affecting ACE receptor, so they're saying that if you're blocking the receptor, maybe that's going to have an adverse effect. Actually, it is to the contrary. When you give an ACE receptor, we actually that doesn't affect it. Now, the non-steroidal anti-inflammatory drugs, NSAIDs, are not advisable in these patients. These patients will get worse. They will have increased mortality. The study showing with ibuprofen in patients, and that's also because it upregulates ACE and ACE2 pathway. In these patients, in COVID patients, there's increased incidence of pericarditis and myocarditis. These patients can come with a normal ejection fraction, normal heart function, EF of whatever, 45, 55%. And within a few days, although they are doing better, you see that they go into flash pulmonary edema. Their chest X-ray that was improving, and now suddenly it is not improving or it's gone worse, it becomes white. And those patients going to pulmonary edema and the ejection fraction have decreased down to maybe 10%, and that's because of the viral myocarditis that is being reported with this pandemic. There is leukopenia and also thrombocytopenia, and there's increased thrombosis. Venous thromboembolism is being reported more and more, and even though their platelets is low, they can be up to 25 to 30. Even then, patients should be given Lovenox or heparin. And that is basically is very, very important to give it to them because they're developing these microthrombi in the pulmonary vasculature, and that is also causing them to be more hypoxic. Compassionate use of inhaled nitric oxide is being used now, in which patients, because of effect on their inflammatory pathway, it is anti-inflammatory in addition to dilating the pulmonary vasculature. It is helpful. We don't know, there's no randomized trial to prove it, but there's anecdotal evidence that it is helpful. So it is being studied right now. There are about 250 patients enrolled in that study. But for compassionate use, we are also using inhaled nitric oxide. So it's very important for the healthcare provider, the doctors, the residents, juniors, even nurses, even receptionists, all those people who are going to see this patient. It's very important to wear adequate PPEs to make sure then the patient comes in, they are put in isolation right away. And proper gowns and proper face shields, all the mucous membrane are covered and protect treat our patients, but also protect our physicians and our allied healthcare professionals which are helping us. With that, I'm going to end my summary, and if I think Rizwan NaeemNaeem is there if he wants to add anything. I did not include any part of diagnosis because diagnostic things that we use, PCR versus antibody screening.
Thank you, Dr. Safdar, for such a cogent summary. So what I would like to do now to start the discussions is to invite each panelist one by one and have them introduce themselves and also make any comments or any additions to your presentation. So I'll just go alphabetically as they are organized in my screen here. So I'll start with Dr. Asima Cheema. Dr. Cheema, please go ahead and introduce yourself.
अस्सलाम वालेकुम, मेरा नाम डॉक्टर आसमा है और मैं मेलैंड में प्रैक्टिस कर रही हूँ इंटरनल मेडिसिन। आई एग्री करती हूँ कि हाइड्रोक्सीक्लोरोक्वीन जैसे डॉक्टर सीरत ने बताया है, one of my patient in ICU I was following, and they gave him hydroxychloroquine for 5 days, and on 5th day he got worse and he was intubated. So again, we don't have much data available at this time, which medicine we can give and which one we cannot give. And one study I was looking for one is done in Australia regarding for ivermectin is, I think, yes. So it's not still, again, we don't have any treatment at this point that we can give to the patient for sure. And again, we know that I think in your hospital, Methodist Hospital, the plasma they gave, I think 4 out of 5 patients cured. So can you please tell more about it? You are in the same hospital, right, Dr. Zeenat?
Yes, yes, I'm in the same hospital. Yes, so you know, it's a very old, as I said, therapy. We are one of the few centers that are offering it to our patients, and you know, it's interesting. It's expected that these will get better. So it's very difficult to get the plasma, but we were able to get it, and we were able to give it to these patients. And I said the volume, as I said, anywhere from 200 to 400, and usually it's a one-time infusion. You don't require repeated infusions.
Thank, thank you. I'll move on to our next panelist, Dr. Imjad Husain. Dr. Imjad, please introduce yourself and make any comments.
Assalamu alaikum. I'm Dr. Imjad and I'm a family physician from Jhang. It's like my second day for joining this talk. I do not have a very much clinical exposure in terms of COVID-19 patient, but as an academician, I'm reading about this disease for like a month or so, and I've been trying to study models in other country, and I'm trying to record some talks. In terms of comments, I would like to say I was just reading Vincent Recaniello's podcast last night, and it was about ivermectin. And they were saying that ivermectin, it's not that useful because the study that's been reflected, it shows that it's just about the cell cultures, and probably it's not going to work in terms of humans. Thank you very much.
Thank you, Dr. Imjad. Your videos on YouTube on COVID-19 papers are excellent. Thank you. I will go next to Dr. Junaid Kalia. Please, Dr. Junaid, introduce yourself and make any comments or questions you have.
Assalamu alaikum, this is Junaid. I'm one of the neurointensivists working at Milwaukee Aurora. Thank you very much for the talk. That was very informative, really appreciate it. A couple of comments. When you are actually thinking of intubating a patient or it's trying to become respiratory wise distressed, if you have the facility, move the patient to a negative pressure room. The reasoning behind is that anything that it can be aerosolized can potentially make a virus move. So one of the key things is to always remember to move the patient to a negative pressure floor or room, whatever that is your possibility. So think ahead in that time. The second thing was, again, anything that can improve the chances during the intubation or aerosolization. So chest physical therapy, nebulizer therapy, etc., should be avoided in these kind of patients, which are helpful in ARDS, which is when the patient actually develops ARDS. At that point in time, you should consider that. Same thing when you do see a PaO2 ratio to FiO2 ratio falling less than 200, when you reach that definition of ARDS, and then you're thinking of proning the patient, before you do that, you should have a very frank discussion with the family as well, because what you're looking at in ARDS is about, data suggests about 33% to 40% mortality. And at that point in time, when you are thinking about exposing yourself and your whole team, you need to have a very honest discussion with the family, and you know that what are the chances, because this is corona, which is different, but anyways, any person that comes with ARDS, as far as from bacterial pneumonitis or other viral pneumonitis, those patients have a very significant mortality. The last question is, people always ask, can prone positioning be done or does it actually increase intracranial pressure? It does not. It is safe in increased intracranial pressure situations. Patients with prior history of seizures need to be monitored via EEG in that situation, just from a neurocritical care background. Lastly, we actually developed a protocol at our place, and we heavily sedate, number one, and we also heavily muscular blockade them. And the reasoning behind, again, is that you don't want them to cough while they're intubating. Again, any chance of exposure to the staff is limited. We tried intubating with one nurse and one physician. It didn't work out. We eventually added another physician just to make sure that things go smoothly. Again, it was important because the exposure was actually anyways getting worse, because then you needed help right away, and then it ended up actually causing more exposure. So again, have a protocol, work with the anesthesiologist or your intensivist group, and make sure there is a protocol developed for it. And again, thank you so much. I learned a lot because I just help out in the ICU situations. I'm mainly in the neuro ICU, but I actually refer to my pulmonology colleagues and infectious disease colleagues, at least at present, to make sure that everyone's running with the same protocol in the hospital. Thank you.
Thank you, Junaid. I'm really pleased that you're here, and I'm trying to bring you back here as many times as I can. Junaid is a really special person. In addition to being a neurointensivist, he is really deep in telemedicine and works with a company on telemedicine. And he's also really an expert on use of artificial intelligence in medicine, especially in neurology, but in medicine in general. So if you have any question related to telemedicine, well, now will be a good opportunity. And also, in addition, about artificial intelligence or its potential role, Junaid will be a good person to answer that. I'll go down the list, and I will invite Dr. Rizwan NaeemNaeem to introduce himself and make any comments.
So I am Rizwan NaeemNaeem. I'm in New York. I'm a professor of pathology. We do diagnostic testing for COVID-19 and other viruses. But I do not have any comments at present. I think if there's a question about diagnostic, I'll be happy to pitch in.
Thank you, Rizwan bhai. Your expertise will be really, really helpful. And then lastly, I invite Dr. Waleed Javaid to make an introduction in his comments. Dr. Waleed, you're muted. Kindly unmute yourself.
Thank you. So my name is Waleed Javaid. I'm an associate professor of infectious disease in Mount Sinai, and I'm also director of infection control and prevention at Mount Sinai. So it was really nice talk, and I want to just raise a few points. Just looking up numbers, in Pakistan currently has 4,263 patients, or at least that's what's reported, or who have been tested. Currently in New York alone, we have more than 70,000 cases, and it's a very different situation. The reason I'm mentioning this is because there's a lot of information we discussed here, but one of the most important things to discuss or think about is planning. Because once this becomes more prevalent, and it likely will become very prevalent in Pakistan, I would probably project in next month or two. If it becomes as aggressive as we are seeing in New York City and other places, it overwhelms the entire healthcare system. So we would prefer everything done in negative pressure rooms, as other doctors have mentioned, and there's 100% agree with that. But there might be times that you won't have those. Having N95 is great. I think one point of clarification is that coronavirus, like every other virus, would likely spread by droplet and or airborne route. But airborne route usually would occur if there's deep infection like lung infection, and or more likely is when we are intubating. So in those times, we need to be very careful about and making sure that people are wearing proper PPE, proper N95 masks. What I'm worried about is in big countries, in European and countries, as well as other Western countries, there's challenges with PPE. So I'm worried about what is going to happen in Pakistan as well. The best protection would really be to be doing things appropriately, protecting, keeping people at the minimum who would get exposed, and also making sure that if you have patients with coronavirus, as others have already mentioned, which I totally agree, having discussions with family is going to be critically important. Project and predict who would require intubation, is there any survival benefit even? And those are discussions you will have to have. above 70 and mostly above 80, the survival benefits really drop and mortality is very high. And that's where you need to have those critical discussions with family, because you are exposing healthcare workers. In some hospitals in New York, they ended up having a lot of healthcare workers, doctors, physicians, and nurses getting ill with coronavirus. So you end up having nobody to take care of patients. So you don't want to get into that position. Maybe I'll talk with Danish and others in detail about later on. Maybe we can do more detailed talks on planning, because that's what most of the work we do. But that is right now you have time to think, time to plan. You don't have a lot of cases. There's a lot of studies, so I'll touch on a little bit on the studies. There's a lot of studies on medication, but there is no proven magic pill yet, right? So there is, as somebody already quoted, that azithromycin and hydroxychloroquine study was disproven. You'll see several things will get disproven. Hydroxychloroquine, I've seen benefits, and I have seen people not having any benefit. So nothing that you read right now has been a concrete medication for it. So prevention and control is going to be key. Making sure, looking at your hospital, if you don't have negative pressure rooms in Pakistan, you can put a fan on the window and make it negative pressure. That's a very easy way of doing it. And it's going to be warm and hot weather. So doing some things, critical thinking about it will be very helpful. Planning now is going to be very helpful. We are seeing a lot of people along with lung injury, which is major problem. Along with that, we are seeing people having kidney injury as well. So thinking about where are you going to dialyze them? Are you going to dialyze them? Things like that are going to be very important in upcoming days. Hand hygiene today and hand hygiene will forever from now onwards will be so critical to prevent this illness. And as somebody already said, we don't really know that if it is going to go away this summer. We don't also know that if it is going to come back. We don't know if our protection is going to be long lasting. But what we know right now is that this is a very big challenge, and it will remain a challenge until we find a cure. A lot of things are being done. They might still be 6 months to a year away. So just prepare to prevent spread of illness in hospitals. I don't want any one of my colleagues, all of you smart people, to get ill. I think I'll end there. I'm very I get very carried away on these things.
Thank you so much, Dr. Waleed, and would love to have you soon talking about planning of management and prevention. That'll be great. And lastly, I have Dr. Sajid Mehmood. Dr. Sajid, please go ahead.
Assalamu alaikum, everyone. I'm Dr. Sajid Mehmood, critical care physician in Chicago area. Very nice summary, Dr. Zeenat Safdar. It was very helpful. I just want to add a couple of things that as far as, anticoagulation for these microthrombosis versus macrothrombosis is concerned, I was going through a recommendation. I am blocking on the source, but the hierarchy which was mentioned over there, that it would be better to anticoagulate with Lovenox, like low molecular weight heparin, versus factor 10A inhibitor, followed by heparin infusion. And that says that there was no effective role for oral anticoagulants, so stay away from them. So heparin can still be used, as you mentioned, but for logistical reason and for another factor, oral low molecular weight heparin would be preferable, so that nursing staff doesn't have to go and adjust the rates, and we should not worry about following PTT levels and all that. And most of these patients who get to the point where we need to be concerned about microthrombosis, their platelet counts are already in dangerous range. So That's what the comment I want to make, that Lovenox might be superior to heparin infusion. And the other thing that is mainly concerned, and my colleagues are paying attention, is this cytokine storm, because that is the uh, thing which we are encountering, especially who have full-blown ARDS and sicker people. And the agent which is mainly recommended for that is tocilizumab. The commercial name for that is Actemra. And there had been discussion in the previous weeks that who should be the right person to receive that. They came up with a score, H score, which incorporate a couple of parameters that we had been following anyways, like LDH and ferritin level and lymphocyte count. But they come up, the calculation is it is tedious process. The key number is 169 they come up with, but I just want to concentrate mainly on the parameters for practical use, that if on these patients who get to the point where we are concerned about using Actemra, so look at that ferritin, if it's more than 2000, LDH if it's more than 1000, CRP more than 5, D-dimer more than 3 microgram per liter, and if lymphopenia, absolute lymphocyte count has to be less than 600, and troponin, even troponin is not that much, but the hospital which come up with this score system, they have incorporated that also. So if you are getting these numbers, of course, with clinical deterioration, then think about, and I think those patients should be considered for use of Actemra, as it in recent weeks or some literature which are out there is supporting its use. Thank you.
Can I add a comment, please?
Ji, please.
All of them are very, very pertinent. Thank you so much. I would just add, in our hospital, what we do, we divide patients into mild, moderate, and severe. So if you have a mild patient, then you can just monitor them, give supportive care. If, as Dr. Sajid mentioned, if they have these parameters with high risk factors as age, comorbidities, and high LDH and lactate level, then they are moderate and they are started on hydroxychloroquine. On the other hand, if they are in a cytokine storm with increased D-dimers, ferritin, CRP, then they get more additional therapy, maybe with ribavirin and IL-6 antibodies. So just wanted to add, I don't know how many of those, especially the IL-6, are available in Pakistan, but hydroxychloroquine is definitely available. Thank you.
Thank you. So I will go towards the questions now in the last 15, 20 minutes we have left. And I want to remind everyone, please put your questions in the Q&A box so that I can get to them. Also, if you would like to make a comment or ask your question directly, you can raise your hand, as I see already a raised hand, and I'll get to you, Dr. Irfan, in a few minutes. And then I also want to remind you that please send an email to appnamerit@gmail.com if you want to be part of moderator or panelist or speaker, or if you have a recommendation for someone to be a speaker. All the previous webinars, this is our day 8, has been recorded and uploaded to our YouTube channel, APPNA MERIT on YouTube. And please feel free to share them with your colleagues and invite them to come here for the discussion and ask important questions from us as things get more serious in Pakistan. So I will first go towards the raised hand from Dr. Irfan Suleiman. Please go ahead and introduce yourself and ask your question. Please unmute yourself.
Thank you, Danish. This is Irfan Suleiman. I'm a pediatric anesthesiologist at Johns Hopkins. And very nice talk by Zeenat Safdar. And so I'd like to comment about the intubation, like we have some discussion about the negative pressure room. Yes, this is very ideal situation, but it's not available everywhere. And also, especially in the Pakistan, rarely they can have this negative pressure room. So most important thing is in intubation is like the expert person. So in the Johns Hopkins, what protocol we have, like we have a like a COVID response team, and that include one of the anesthesiologists, expert anesthesiologist. So we don't allow any trainees to intubate because this really need to be intubated as quick as possible. The person who is intubating is a very high risk to have this infected. So we should have a proper PEE. And also I like to, if you allow me, I like to share a couple of pictures that give you an idea, and that will be very beneficial for here and also very beneficial for Pakistan. Is it okay, Danish? I can show this picture.
Yes, you can, but I'm not sure how to. Are you able to share the pictures?
Yeah, I'm sharing.
Okay. Well, Waleed, can you get to Dr. Irfan and see if you can get the pictures to share? And let
Can I
me.
mention, Danish, can I mention one thing? You know,
जी,
in our hospital, हम लोगों ने एक plexiform plastic का एक बनाया है, एक like almost like an enclosure that separates the person who's intubating from the patient. जिसमें आपका सिर्फ हार्ट डालते हैं, and I can share the prototype. It's a 3D printing, 4D printing, so you can make it yourself. And there are two different forms, and I will share that design with the participant if they like. And that's easy to make. It's plexiform, and that protects the guy or person who's intubating from the direct effect of aerosolized virus, and they can intubate just with a mask, and they don't need special intubation kits.
जी बिल्कुल, Dr. Zeenat and Dr. Irfan, please share those resources. We have started making a resource document with collection of all these resources, and we're putting it together. And if you just send us the link, we'll have it available for our participants going into the future. जी, Dr. Sajid?
Oh, I thought Irfan is still talking.
No, please. Do you have a comment or?
Yes, I just want to say that in my hospital, and I'm sure that now in other hospitals, the PAPR, powered air purifier respirator is used. If that's available, that I think that it's recommended for all of them, even though previously those people who have beard, because they were not appropriate for N95 fitting, that's why. But now I am seeing that more and more people are using that, because that will provide you ultimate protection. I mean, it is covers your face and head, except for ears for stethoscope use. But if you want, you can cover your ears also with that. So if pepper is available, that would be helpful. And I echo Dr. Zeenat comments that shield device that we are also using, that is also very helpful, because it covers the patient who needs to be intubated, his head area, and then keep other people who are involved in the intubation process protected. Thank you.
Dr. Irfan, you have a follow-up comment?
Yes, I just want to, because I cannot able to share the picture here, but like the most important thing is patients should be intubated by the expert, and prefer is anesthesiologist. Number two, patient should be paralyzed. And number important thing is, if you have a glide scope in the hospital, should use that. That significantly minimize the risk, and it's easy to intubate, because if you're doing a direct laryngoscopy, you are almost very close to that. And as the Zeenat mentioned about the plastic drape, that's the same thing where we develop. And if you dab, that's another minimize the risk. On the top, we have anesthesiologists have a shield, triple gloves, 2 gowns, and N95 mask. So all these, like in addition to all these things, that will be minimize the risk of the anesthesiologists get infected.
Thank you, Dr. Irfan. Let me try to get to some questions, because we're on the last 10 minutes here and I'm not able to get to the first question yet. Let me see if I can quickly go to some of them and get quick, short answers from the speaker and the panelists, so that we can cover at least a few of them. So let me start with the first one about plasmapheresis. There was previous discussion on convalescent plasma, but is plasmapheresis also being used to try to make the patients better? Dr. Zeenat?
I have not come across any data for plasmapheresis. I mean, if you think about it, it would make sense that if you're going to take out the virus, but I do not know if the filter that we use for plasmapheresis is small enough or that small to filter out this virus. This virus, the size of the virus is anywhere from 70 to 380 micron. So it's a very, very small virus that I do not know how long it stays in the bloodstream because it really, you are inhaling it and it's going into the lungs. So I do not know if it's actually circulating in the bloodstream that you can take it out. I think what it does, it attacks the alveolar epithelial cells and causes problems. Thank you.
Any panelists have any comment?
Yeah, so I agree with Dr. Zeenat in this that it technically wouldn't make much sense. It may help, may not. It is likely one of those experimental therapies, but the injury is in lung. Even if there is some viremia, if there is some virus in the blood, it wouldn't make a lot of difference to do plasmapheresis as it pertains to the lung injury itself.
Okay, let me go to the next question. The question from Dr. Tauseef Irfan. How long does the COVID-19 patient remain infective and transmit infection? Dr. Zeenat?
Yes, so as I mentioned earlier, up to 24 days. It's a long time. So usually the quarantine time you get is a patient should quarantine themselves for 14 days. We know that the incubation period before they become symptomatic can be anywhere from 2 to 7 days. Mean of 5 days is reported. So after your exposure, a patient can become symptomatic anywhere from 2 to 7 days, and they remain infected up to 24 days from the initial exposure.
Dr. Rizwan?
So this is again knowledge about people in our morning meetings where every discipline people come together and talk about patient. So one of the things we realized that, as you may know, that viral load is also a very important factor in severity of disease. And what happens that if the viral load is too high, the cytokines start secreting tremendously, what we call it as cytokine storms, and that need to be watched. Again, patients who are at home and mild symptoms, they need to be very carefully monitored, and especially if they are in hospital, that enzymatic activities should be monitored very carefully. And once you are in a cytochrome storm type of situation, it's called cytochrome storm syndrome, if I'm correct. And that can give a lot of problem to patients. And I wanted to see what Waleed or Zeenat or Sajid have any comment on that.
Thank you. The next question I have is, where are the swabs taken from during drive-through for coronavirus screening? Are they throat swabs, nasopharyngeal swabs?
Right now, they are nasal swabs. Initially, we were doing nasal and throat swabs. The data suggests that the nose swabs are as good as the throat swab. If the patient has a lot of secretions, there are patients that are asked to clean those out and then do a nasal swab. But in some cases, we have seen, especially in the hospital, that the initial 2 swabs are negative and you do a 3rd swab and it's positive. So if you have a very high index of suspicion that this patient has COVID, even though the testing comes back negative, I would still suggest keep the patient in isolation, negative pressure. I mean, we have developed technology in which we have used a vacuum to create a negative pressure room. So a vacuum cleaner and things like that. So I can share those prototype with you also.
Panelists? Okay.
So for testing, I think a nasopharyngeal swab is the most preferred, but some testing. So it really depends on what kind of kit you're using, and you should follow what the manufacturer is recommending for that. And as Dr. Zeenat already said, that there is this sensitivity of all the tests that are currently available is not 100%. We are seeing around 80% sensitivity, and that really means there are cases that we may miss, and that needs to be kept in mind. And high clinical suspicion should drive isolation.
Thank you. Next question I have is that what kind of muscle pain are we expecting? Are they cramps, heaviness, or pain at the joints or tendons?
So it's basically, it's like you're having a flu. It's just muscle aches, really, really bad muscle aches. Somebody said it feels like your legs and your arms are like stone, patthar ke. You know, that's bad. It's not joint pain, but mostly are just heavy. It's a lot of fatigue. Patient can lay down and you may take a nap for 15 minutes and you wake up, it's already 3-4 hours. And also a lot of chest pressure.
Panelists, any comments? Okay. And the next question, Dr. Zeenat, is about, are there any alternate therapies to that IL-6 antibodies that you mentioned for Pakistan?
I mean, I don't know exactly what's available in Pakistan. I did mention that if you have antiviral therapy for HIV, those are being investigated. That's an easy thing to get. Ribavirin is also being routinely given now, and maybe that's available over there. Hydroxychloroquine, and I would defer to my infectious disease colleagues to see if they have any knowledge of what's available in Pakistan.
Ji Sajid?
Yes, I think if this question is particularly related to Pakistan, so I can bet that except for a selected institute, this test might not be available in interleukin-6 antibodies. So in those cases, I guess they should concentrate on these parameters that I mentioned earlier, that ferritin level, LDH, C-reactive protein, D-dimers, and lymphocyte count. If that are positive and elevated, then I guess they have enough reason to consider these patients to be in cytokine and possible candidate for IL-6 inhibitor and like Actemra. But that leaves us with another question, that if interleukin-6 antibodies are not available, so whether these specific agent tocilizumab or Actemra is available or not, and if that's not available, then what would be an appropriate alternative? That I guess the specialist in Pakistan, they can answer better.
Ji, Dr. Waleed?
So as everybody else has said, most of the treatments are experimental, and I would stress on the prevention side. But again, what most of like using steroids and other things may or may not be helpful, and I don't think we can kind of bet on this drug will help or that would help. I think preventing the illness and supportive care is going to be more critical than anything else, at least at this time.
Great, thank you. So I have a couple of more questions from today to go through, and I have a bunch from yesterday, but I want to invite attendees that if they have any comments or questions and they want microphone, please raise your hand and I will try to get to you and take your comments or take your questions live. So the next question I see is from Dr. Moten about the inpatient care providers who may be asymptomatic. Should they be screened every few days for coronavirus patient?
So for hospital employees, that's what the question is about. Sorry, is that?
I think so, but it has both things mentioned, both providers
Yeah.
and patient. Let me get to Dr. Moten and see if she want to ask this question directly. Dr. Moten, please unmute yourself and go ahead.
Assalamualaikum. I'm a cardiologist, and my question was, we do come across patients that may have lymphopenia, thrombocytopenia, low ejection fraction, and they are not COVID positive, but later on they become COVID positive. And that means the people that have taken care of them, they have been asymptomatic and they could have been carriers. So the question becomes, should they be provided with face mask or should they be screened every few days?
So I understand what you're saying. And a case that you described in the questions, I looked at that as well. It's likely that it wasn't transmitted by the providers, but it's because of this sensitivity of the test that's not good enough, and probably it's an operator error in obtaining the test as well. That were probably is in effect. So sometimes we don't have enough viral load to detect the virus, and if there is compatible clinical picture, we should always consider those patients to be high risk, and that's what we're trying to do. Anybody with bilateral viral pneumonia or bilateral fluffy infiltrates in the lungs, even on chest X-ray, we would consider them as high risk. Even if the first test is negative, we usually repeat it. I think second point would be as this gets more prevalent, one of the things the hospitals and other institutions should do is to actually keep an eye on all staff and do some sort of symptom monitoring by their superiors, just to make sure everybody who's coming to work, it doesn't have symptoms, so we don't have internal spread of this infection.
Thank you. Dr. Tauseef Irfan, please introduce yourself and make your comments.
Can you hear me?
Bilkul, we can.
I'm Dr. Tauseef. I'm a family physician working in rheumatology. And we have been using tocilizumab Actibra in children in systemic GIA. And mainly we have some experience, and therefore it is available in Pakistan. So we just had this discussion about IL-6 inhibitors. I wanted to inform that it is available.
Bahut shukriya. Thank you. Dr. Kalim.
Assalamu alaikum. This is Dr. Kalim Ahmed. There's a discussion, I think we are having this discussion again and again about the steroid use. Let me be very clear. The SACM guideline, which is just published, has recommended 2 locations in their guideline. We are having this discussion for Pakistan, where all the sophisticated thing is not available. And these guidelines, which from the sepsis trial people, which I have already reviewed on my 4th day of this session, 2 occasions they have telling us they use steroids, especially in patients who are ventilated and has ARDS. It's a weak recommendation, but they are recommending it. And in the discussion, they said majority of the panelists out of 36 who has reviewed all these data from 12 countries, they come up with these guidelines. And they're suggesting that using 1 to 2 milligram per kg Solimerdrol in 24 hours has medications. And also in severe sepsis, when we are unable to maintain patient hemodynamic and blood pressure, after using liver-fed norepinephrine and adding vasopressin, this is the line. Norepinephrine first, then vasopressin. If vasopressin is not available, then epinephrine. And if the blood pressure in mean artery pressure is not maintained to 60 to 65, using hydrocortisone at 200 milligram, either infusion or in divided doses. These are the recommendations on the basis of data. So I just want to make a point here, especially in Pakistan when we don't have all these sophisticated medication available. Thank you.
Thank you, Kalim bhai. So I again invite all the attendees who have not had a chance to speak on this platform before. This might be the first time, or if it's second or third time, but they have not spoken before. Please raise your hand and I will get the microphone to you and get your introduction and comments from you. Otherwise, I'll continue with the questions, a couple of more, and then we'll wind down and stop the meeting for today. So I have a question about can COVID cause early lung fibrosis, and patients be putting on ventilator, can they become vent dependent because of this?
I'll take that question. We don't know yet. If you look at ARDS and acute lung injury, we know that patients who recover from that, recover from prolonged intubation, recover from prolonged lung injury, they have residual pulmonary fibrosis and they do develop it. And if they're on vent dependent and they get a tracheostomy, they will have all the sequelae of ARDS. When a patient is not intubated, the patient does not just get a mild or moderate disease and they are not on the ventilator, or they are on the ventilator for a short period of time. I don't suspect that they will develop long-term sequelae, or even if they do, it's not going to be too much or noticeable.
Thank you. So, I want to take a couple of minutes and go to our couple of panelists who haven't had a chance to speak much. I especially want to hear from Dr. Imjad Husain because he's practicing in Pakistan and knows the ground realities. And I want to hear from him. There are questions about the cost of lab testing, the availability of lab testing and diagnosis, and the use of face mask and seeing patients in the private practice as they continue to do so. So Imjad, please go ahead and make some comments on these and any other comments you might have in your mind. Imjad, please unmute yourself. Sorry. Ji, go ahead.
Hello. Ji, Assalamu alaikum. I'm not seeing much of the COVID patient at the moment here in Pakistan, but as far as I am seeing, it's mostly other specialties patient, but I also observe that there are a lot of patients with comorbidities here, especially like we have so many patients with diabetes, hypertension, and chronic pulmonary disorder and heart disorders. So I think a lot of people are having pneumonias, and because of this testing thing and scarcity of resources, we're not doing testing actually in a way. The way we should be doing, like the way WHO has recommended that you have to do both the antibody testing and the PCR testing. I'm not sure whether they are afraid of the rising number of cases, like if they start testing, or maybe it's because of the substandard level of testing providing with the kits, the IgG, IgM type of testing. I heard it was available once in our like nearby lab, and then they kind of suspended. And regarding treatment, I'm not sure that we have so much on that paradigm. And in terms of ventilation and ICU care, that would be an issue in Pakistan. So what I recommend to most of my colleagues in Pakistan is that we should be focusing more on the preventive side of it. We should be masking all, as we have seen in United States. First they said that you do not need to mask everyone, and then now the latest report about masking is that you have to mask everyone in the community. Even DIY mask, do-it-yourself mask is a good option. It will be putting a barrier between you and the patient. So I think we should be focusing more on the side of prevention. We do not have resources for even testing, and treatment would be just like, especially in terms of ventilation things and other. We do not have ICU stuff, and even if we have ICU, we won't be having much of the intensivist and training. And we should be actually training physicians on ventilatory things and other stuff, and about triaging. We're not doing even the basic stuff in Pakistan.
So you practice in Jhang. How many ventilators there are in Jhang, if you're aware of, and what's the cost and process of the testing for COVID-19?
The cost and process of testing is not available privately. It's only at the select lab, and even select lab like Aga Khan and Chuktai lab, they said, but they, I think, work in collaboration with the NIH. So it has to go through that pathway only. So, and people
who can
have
order
to pay
the test?
It could be only ordered through the governmental setup. One has to go to the district hospital, or for example, in Jhang, there is just DHQ hospital where you go and you report to kind of a special isolation unit. And from where if they suspect you are having you are PUI, then they will send a test for you. and they are not doing my testing. To my knowledge, I have seen like if I see so many patients in hospital, and I think they should be suspecting it. But
In ventilators, do you know how many there are in Jhang?
ventilators, in terms of ventilator in our hospital, I'm in a private setup. We do have 1 or 2 ventilator, but we do not have a proper ICU, and human resource is the main issue here. And in terms of district headquarter hospital, I think they do have 1 or 2 ventilators, but there is no dedicated ICU. They have a kind of makeshift ICU for surgical patients, especially when they are intubated or something, lung injury, or they do not have a medical ICU per se.
Thank you. Thank you for your comments. So I invite Junaid, Dr. Junaid Kalia, to make any comments or additions to the discussion today.
No, I mean, to be honest with you, I learned a lot, and I'm going to go back and look at all the videos. One of the reasons that you asked was the role of telemedicine, and I think that is something that we need to really concentrate, especially in Pakistan as well. And you have commented in the PINS group as well that we need to make sure that some of this is available. Like, for example, right now from 8 p.m. to midnight, we can actually help our colleagues back in Pakistan. So if there is a process that can be developed, I know this is hard times, but we should really look into that. The second comment, as I said, again, it's a hard thing to say, but sometimes the cost of life is too much for the living to bear. And it's in this situations. I come from a humble beginning as well. We have to be very careful what we wish for in certain situations. And over here in US, my situation right now, I'm not asking some of these patients that I'm going to make them DNR. I just do it. Because at the end of the day, it is something that I have to take care of my staff. I have to take care of, the whole equipment situation and everything. So when we are dealing with situations in Pakistan, again, one more thing, of course, definitely go with the steroids. And then secondly, early, because the faster you get into it, the better it is. And then the second thing would be to actually have those sort of back in your mind to talk to these families, because it's hard discussions to have.
Thank you, Junaid. Dr. Zishan Ahmed, please go ahead and introduce yourself and make your comment.
Assalamu alaikum. My name is Dr. Zishan Ahmed Chattha. I'm a resident in anesthesia, and I'm also into general practice, and I'm running a small hospital in the vicinity of Islamabad. We have a multi-specialty hospital. Regarding the comments made by Dr. Imjad, I think if I'm correct in the name, the testing for PCR testing for COVID was not available as widely before, but the NIH had taken an initiative, and they had written letters to all the hospitals and all the major labs of Islamabad, Rawalpindi, and the major cities of the country. And they have asked them to, they have promoted them to start testing for COVID, so that the burden is shared and the number of testing is increased. In that sense, many of the hospitals over here are starting. I've been to NIH yesterday, and they are collaborating. They are guiding everyone how to set up, how to make the infection control protocols and everything. Our hospital is also going to be starting the testing within a week, hopefully. I've heard that PF Hospital, Fauji Foundation, they are also in the process of setting up, and the number of testing would be increased in coming days, inshallah.
Thank you. Dr. Abdul Naeem, please go ahead with your introduction and comment.
Assalamu alaikum. Thank you, Danish. I am Dr. Naeem from Islamabad, family physician. As the things are going about discussion about the work facilities over here in Islamabad, as Dr. told that NIH is conducting the PCR. Actually, the only PCR is recommended by the government officially, and antibody testing is not allowed yet due to lack of, you can say, the genuinity or specificity like these issues. Government is allowing only PCR, and right now NIH is conducting. You have to go to PIMS. They fill up a certain you can say form, which symptomatics, they score the things, and then they refer this or take sample to NIH. Other than that, there is no specific lab that is conducting PCR over here. And on the ventilators, when the issue was started in Pindi, Islamabad, only 42 ventilators were available in Islamabad, Pindi, Army, and Civil. This is the condition right now over here. Thank you.
Dr. Iqbal Ahmed, please introduce yourself and make your comments.
Assalamu alaikum, especially to all the colleagues in Pakistan. I'm here in Dallas, Texas. I'm a cardiac anesthesiologist here and involved in our hospital preparation. And this question is to all the colleagues who from Pakistan who have very generously given their time and praised us of the situation. So I'm curious as to if there is no testing and we don't really know whether how many people are there in the communities in Jhang and Islamabad and in the areas that you represent. Have you observed as a physician, as a family physician or as an anesthesia resident, an increase in number of patients coming to the hospital who have severe respiratory illness? They've not been diagnosed or confirmed, but is there a unusual rise in severe respiratory illness? Thank you.
Let me start with Dr. Imjad, and then I'll go to the attendees. Imjad, do you have any comment?
Yes, Hello. Yes. I think regarding number of patients, if they are increasing in terms of respiratory, I don't think we had a data or something about what kind of patient are having before the COVID thing started. Especially with this, I think even in hospital services are kind of they are not offering full services. Even surgeries are limited. And yesterday we were thinking about like closing outpatient department for services like those are not non-essential services like ophthalmology, dermatology, and few other outpatient departments. So it's not the usual traffic in hospital these days. And as for example, I'll tell you, I was just doing a round in a medical ward and there were like 20 patients admitted and at least 8 or 10 of them were admitted due to respiratory symptoms. Some of them were previously had the chronic pulmonary condition, then some of them had tuberculosis, and some of them they developed pneumonia post-stroke. So unless we're going to do testing, we are not going to know how much disease in there.
Ji Abdul Naeem.
Assalamu alaikum. Actually, the thing is that in Islamabad, we are at the highest level of pollen allergy in Islamabad. This is the city where you can see the most of the patients have pollen allergy. Our patients in Islamabad, they are confused with the cough, dry cough, and shortness of breath with the pollen allergy and the corona. And most of my old patients, though I know them, they previously had the pollen allergies. So this, I can't say strictly that more symptomatic in the respiratory system patients are coming, but we have also other burden, that is a pollen allergy in Islamabad. This is the reason that they are coming more.
Ji, Dr. Zishan.
We've not had any unexplained respiratory patients or an increase of respiratory symptoms to patients. But there are patients who have presented with atypical symptoms or very mild symptoms like very mild fever, and a few days later they turn out to be COVID positive. So that's it.
Dr. Rizwan NaeemNaeem, you want to make comments on testing? Okay, and Dr. Kalim, you had some comments?
No, actually, I was talking to just today my nephew. He is in the ER at Al-Khan, and a week before, they were kind of bombarded with a lot of patients coming into the ER. And his take was that last week they have 4 patients positive out of many they tested at AKU. That's a snapshot. Don't know how to extrapolate this information. And I'm in contact with him on a regular basis. Dr. Fizia also joined us mostly almost daily basis. So we can get the data from their institution, and I'll try to get more data, and inshallah we'll try to share it on those centers where they are not having problem with the testing. Testing is readily available. So we can extrapolate after getting multiple different institutions and get a better sense of it.
Thank you, Kalim. So I think we'll stop here. We started at 10:05 and we're 15 minutes past our hour. So it's 11:20 here and probably 9:20 in Pakistan. So thank you so much for everyone for coming, and we'll continue the discussions tomorrow. Leave your questions on the WhatsApp platform or email it to us. Thank you so much. Have a nice day.